Hi there, I'm Jennifer Kennedy, the lead for quality, standards, and compliance here at CHAP, and welcome to our CHAPcast. Today we're going to be discussing the top 10 2023 CHAP hospice standard deficiencies and their potential impact in the bigger picture, as well as strategies for success. Again, whether you're new to hospice or whether you've been around the block for a while, today's information is going to help you exceed standards 24/7, 365. So I'm so pleased to be talking with my coworker and friend, Keri Culhane. She is with CHAP as our clinical nurse educator, and this isn't her first round of being at CHAP. She was with CHAP previously as a director of accreditation. Keri has 18 experience in the post-acute healthcare industry, and she's held a number of different positions from direct patient care, a clinician as a registered nurse, to a chief executive in both home health and hospice organizations. She does have a passion for community-based care, and she does a great job, because we know she enjoys it, of educating others and contributing to not only their growth and development, but their overall um, uh, quality, I'll say, as a healthcare professional. So welcome aboard to CHAPcast, Keri.
Thanks, Jennifer. I'm glad to be here.
Well, we're going to talk about hospice deficiencies. And when we're talking about noncompliance with regulations, I think this is one of the most important times in the history of hospice in the United States where compliance is paramount. We now have the Hospice Special Focus Program that one of the criteria links to 11 quality of care COPs, and receiving a condition level deficiency in any of these 11 quality of care COPs could be one of the variables in being invited to participate in this special focus program. So I'm really happy to be talking with you today and running down the 2023 top CHAP hospice standards deficiencies. So let's dive in and let's talk about what's topping the list in hospice care and what trends you're seeing in the 2023 data.
Well, a few things that are of note for 2023. One of them being our top deficiency has remained the same from 2022 as well, and that has to do with plan of care and the content and elements of the plan of care. And then we have a number 2 moving up in the ranks in our top 10, and that has to do with a comprehensive assessment of medications and ensuring a complete and accurate med profile. Several of our deficiencies in the top 10 remain in the top 10 over the last several years. We have some movement in terms of ranking. Although we do have 2 new deficiencies that came into the 2023 top 10 this year, respectively at 9 and number 10. And that has to do with standard precautions, lack of appropriate hand hygiene, as well as completing that initial bereavement assessment, as well as making sure that it's completed in that required time frame.
Wow. So I'm not surprised about number 1. I don't think CMS thinks that hospice providers can do an adequate plan of care. But, CMS also thinks that CMS is the plan of care is the most important document in hospice care. So I think there are a number of variables around why there's deficiency there. But I guess what I am hoping you can do for us is, quickly walk us through what those 10 look like and some of your thoughts about that.
Absolutely. So, of course, number one, plan of care. And Jennifer, you hit the nail on the head. This is one of the most important documents, and really what I like to call is ever evolving. It's almost living and breathing, for lack of a better word, because it is constantly changing depending on what is going on with the patient and what that assessment is yielding in terms of findings. So, very important that organizations understand the importance of the individualization factor. And biggest thing we see in terms of lack of compliance have to do also with how they're developing those goals and making sure that those goals are what we like to call SMART goals. So they are specific, they're measurable, they're achievable, realistic, and time bound. And then also making sure that those interventions that are developed are individualized, and that the clinicians have a good understanding of what it means to really develop that plan of care based on what is going on with that, what the patient's needs, and not
And
so
what they
much.
want, what the patient's wishes are, right?
Absolutely, absolutely. And that's a great point, because at the end of the day, we're there to make sure that the patient's goals and the outcomes that they want to achieve, we can assist them in meeting those. So absolutely. Because this is such an important issue and we see it pop up as a deficiency so often, we do have a micro learning that I'm putting together related to care planning that will be available on our education page here very soon. And it really will focus in on breaking down care plan development. What is the difference between an intervention and a goal? What does it look like to really individualize those and make them patient specific? So stay tuned for that. More to come on that when that's posted, but hopefully that will be a very useful resource for organizations to also then share with their staff on really how to develop those plans of care and individualize them according to the patient's needs.
Wow, huzzah. I can't wait to see it.
It was very fun to put together, I must say. So I hope you would find it as fun as I did putting it together. So then coming in number two, which I said this has moved up in the ranks. It was still in the top 10 last year, but now moving into that two spot is the assessment of medications and ensuring that complete and accurate profile. And this also is another area we see, especially when you're out on home visits and observing the staff conduct that medication reconciliation process, and really educating your staff on those questions that they can ask to investigate and really be a detective when they're out there and observing what's in the home, what they might see on a nightstand or an end table. Ask those questions to try to compile as accurate of a list as possible, and to be conducting that process not only at start of care or reach certification, but also on an ongoing basis on routine visits to make sure that that list is as accurate as possible, and also making sure that it's matching what is in the record. So not only completing that accurate profile in the home and leaving that there for the patient and family, but then making sure that that is put in the record as well, so that they match and there aren't any discrepancies there. And then 3 and 4, I'm going to talk about these together because they both have to do with aid services. And coming in at number 3 is the development of the aid assignment or the aid care plan. And really, what we see there is a lack of clear direction on those aid care plans for the aides. It's the aid scope of practice is very limited, and it also can vary depending on the state. And so, making sure that the nurses are aware of what the scope of practice is for the aides in their state, and then providing that clear direction on what the aide can and cannot do on that assignment sheet, and educating them educating the aides really to notify the RN if there are any issues, or if they are unable to complete a task for whatever reason, or if they want to ask permission to do another task that's not on the assignment sheet. And then following that is the aides actually implementing and following what is assigned on their assignment sheet or care plan. That comes in at number 4. So really making sure aides understand that they are limited to those tasks that are given to them or assigned to them on that care plan, that they understand that if there is a request from the patient or family to perform maybe a different bathing type that's ordered, they need to call and get permission from the RN before proceeding and completing that task. And then also understanding when they are reporting any changes in condition, and whether it's pain, whether it's maybe a new wound or a new red spot on the patient, that they understand that they are reporting that information to the nurse as well.
Keri, not that these two aren't important, because they are, but I'm so glad you didn't say the every 14-day supervisory visit. God, that has just been such a theme, with, at least at the CMS deficiency level, for years on years on waffles.
Mm-hmm.
It's just, it just never goes away. So I'm happy to hear that it's not here, but I do think nurses have a bigger responsibility. When they have an aide in, they absolutely have to manage that aide in all aspects, including knowing what's on that care plan at any time, but also updating it and educating the aide. So in a way, I feel this is a failure of the nurse working with that aide.
And it's also that I think a lot of organizations are able to maintain compliance with that 14-day requirement because they've instituted the process of every visit the RN is going to be conducting a supervisory visit on the
Right?
aide. But I also think, and what I've discovered, in my years of surveying, was a lot of nurses didn't understand the true meaning of what it meant to supervise that aide and to really be evaluating their documentation, comparing it to that care plan, making sure they're asking appropriate questions during the supervisory visit of the patient family on how the care is going, what types of services the aide's providing. There's a lot that the nurse can learn by asking those questions, and also by really evaluating the documentation component. So
Yes,
that
consistently, right? Consistently.
yes,
Yeah.
yes. So you're right. The 14-day one is probably not too far off the top 10 list, I would imagine, but it
It's right. It's
didn't make it
close.
this year. It's so let's here coming in at number 5. We have the patient clinical record containing physician orders. So making sure that when those clinicians are getting orders from the physician, they're making sure to document those. We being in the field and in patients' homes so much, we do a lot of verbal communication with the physicians and get those verbal orders. And it's just really important that staff understand how important it is to document those and capture those in the record as well. And then coming in at number 6 is completing that initial comprehensive assessment within that 5 calendar day window after the election of hospice care. And so making sure that, those disciplines are reaching out, and if they're not able to get out there, or if they're refused for one reason or another, that the RN is really key in collecting that data and documenting that in the assessment. And one thing that I always like to educate organizations on is if a discipline is refused, or the patient does not want them in the home, that doesn't mean that they're not still participating and providing input, especially during the IDG process. Um, you know,
Absolutely.
and the RN can be communicating that with the team, and that chaplain or social worker can be providing some input or guidance to the RN if they are, refused and they don't want that discipline out there. So it doesn't mean that they get a pass and their hands off. It just means that they have to do a little bit of more work with that nurse within the team setting, and really work together still to meet those patient and family needs.
Yeah, thanks for saying that. It's so important, I think, and I wholly agree. It's not a vacation, because you're not in there. You're still in there. Mentoring your team members on what they can do on the social worker, spiritual care counselor behalf.
Hmm.
So yeah, for
Absolutely.
sure.
And then coming in at number 7, we have if the patient revokes the hospice benefit or is discharged, the hospice is forwarding a copy of that discharge summary to the attending physician and making sure that that summary is comprehensive in its elements. So organizations need to make sure there's a process in place to make sure that summary is being completed and forwarded to the attending, and making sure that that summary is indeed a summary of the patient's stay and what transpired throughout their certification periods, however long that may be. And then coming in at number 8 is making sure that services and the care that's being provided are following the individualized plan of care. And here we do see a little bit of more of an issue related to visit frequencies. So making sure that visit frequency, the disciplines are identifying in the plan, are being met and followed according to the plan of care. And if not, making sure there's documentation to indicate why a visit might have been missed, or what the case may be. So making sure that the record is painting that picture and providing that evidence of why that standard might not be compliant.
And again, the scope of practice and the frequency is per the patient and family's needs, not per your staffing issues, right? So
Absolutely.
I know it's tough out there. I understand that some hospices and home health, or they're trying to do more with less, but um, we have to make sure that the patient's not getting shortchanged. If they need 2 times a week, 3 times a week, then we have to have somebody out there doing it.
Absolutely. And what I love to see is a fluctuation in visit frequencies as the certification period's going on based on what the patient's needs are and what's transpiring. Again, I mentioned earlier, it really is a living and breathing
It
thing, that
is.
plan of care. So seeing that movement in the documentation and at the ebb and flow really does reflect individualization and focusing in on what the patient's wants are and what their needs are.
Absolutely.
And then we have our last two. Again, these are new for the top 10 this year for 2023. And number 9 is following accepted standards of practice to prevent transmission of infection. So standard precautions and appropriate hand hygiene. Again, this is so important out there. It is such a basic function in terms of your hand hygiene processes. But it is a challenge when you think about the environments that the hospice staff are going into, whether that's a patient home that may be, not the most clean, or maybe has a lot of uh, stuff, like we like to call it, where they're having to figure out where they might be able to place their bag, um, if they have access to a sink, and be able to wash their hands, etc. So really important that organizations are observing their staff in the field, seeing how they can adapt to those situations in the environment in order to still maintain appropriate infection control practices. And
Keri,
ongoing yeah, go
I
ahead.
was just gonna say, as you're talking, I'm thinking back to my days out there, of challenging household situations. But I would have thought after COVID things would have gotten better with some of these basic things like standard precautions and hand washing.
You would have thought that, there was so much education and training going on during the public health emergency. But what I also saw surveying in that during that time was a lot of inappropriate glove use, which there was a lot of individuals that started wearing gloves and due to the pandemic, and
Hmm.
concerns about their own safety. But there was a misconception on what that meant in terms of when they have to perform hand hygiene, when those gloves should be changed. It was kind of this mentality of, gloves are on, I'm safe. I can pretty much do
Right.
anything because I've got gloves on. So there a lot of education related to appropriate glove use. And I think the more staff get into a routine, and the more they really have to be self starters. The way I look at it is they really have to be mindful when they're out in the home, and really develop their own routine so that it just flows naturally for them. And when they're being observed or when they're in a new environment, they have really adapted a routine for themselves that works, and they can just seamlessly, hopefully, implement that from home to home, depending on the situation. But lots of ongoing education and training. We say repetition is the key to adult learning, so the more that they're seeing and visualizing or practicing these type of skills, the more it hopefully will stick and become a part of their routine processes going forward. And then last but not least is the initial bereavement assessment, and making sure that that is completed as part of the initial comprehensive assessment. And it's also important to note that if the other disciplines are refused, I know a lot of organizations have policies where typically maybe the chaplain or social worker may be conducting that bereavement assessment. But keeping in mind that if those disciplines are refused or are unable to get out there within the appropriate time frame, that RN also can be conducting that bereavement assessment as well, and making sure that they're also sharing that with the team, getting input from the team if those disciplines are indeed refused. But again, it is a team approach to the care for that patient. So the nurse can definitely be obtaining that information and completing that assessment as part of the comprehensive assessment.
Yeah, absolutely. I know that it's, depending on the patient, they may not want certain disciplines. So it may end up that a nurse has to do that. And even if the basic assessment is completed for bereavement, depending on the outcome, an expanded assessment may be required. So, ties back to you don't get a pass from the IDG table if you're not actually
Absolutely.
hands-on in the house, for sure.
Yes, absolutely.
So you've given us a lot of good information as you've reviewed the deficiencies, but are there any other overarching um, practices or measures that a hospice provider could take to meet our standards and hopefully exceed them as it relates to their performance?
I think two areas that really I think about when I think about trying to exceed expectations and really focusing on quality patient care. And one would be making sure you've got dedicated education and training for your staff. I think when we talk about these deficiencies and those ways to come into compliance, a lot of what we say is ongoing education and training. And that is so important that staff understand, let's take care planning, for example, how that process is supposed to be developed, and providing them with the tools needed to develop that individualized plan of care. Giving them specific education related to reconciliation and how to really compile a comprehensive medication list. And then again, with basics as hand hygiene and bag technique processes, making sure that they are receiving just ongoing education training, real-time observations, so that they are prepared. So that's one area I would say is definite education and training, and investing in your staff and providing them the tools and resources necessary to be successful. And then a second thing I really would focus in on is making sure that an organization has a robust, comprehensive quality improvement program, where they're really looking at a variety of indicators, doing their audit processes, collecting that data, honing in on those areas that they've identified either through their own internal processes, or taking some of these top deficiencies and really looking at them and internally, and how they are where their compliance level is with these in terms of their own processes. And then developing in projects, if they're finding those deficiencies, identifying opportunities where they can really come together, develop a project to make improvements in that area, and demonstrate that improvement and sustain improvement. I think one of the areas organizations struggle with is they may get to that goal, but then how do they maintain that compliance on a long-term basis and not let it, for lack of a better word, fall off the radar, and something that they're not keeping up on. So making sure that they've got those ongoing monitoring processes in place, to keep things where they need to be in terms of compliance.
Wow, those are great tips. And it's been really great chatting with you about all this. I think one of our calls to action for our listeners out there today is to um, not only look at the list of top 10 deficiencies that we'll include with our episode notes, but we do have what we call CHAP accreditation intensives. And I know you just happen to teach those. So,
Yes,
um,
ma'am.
can you give me a couple of points about the hospice intensive?
Absolutely. So we conduct our intensives several times throughout the year. In fact, we have our next one coming up, I believe, towards the end of August. And we really focus in on each chapter of the hospice standards and break it down on the more granular level, what each of the standards mean, what guidance is related to interpretation of those standards, what are the top deficiencies as it relates to that specific chapter, and providing organizations with tips for success on how to bring those areas into compliance and demonstrate compliance moving forward. We strive to make these sessions very interactive and engaging. There's a lot of discussion amongst groups. There are breakout activities that we focus in on, and the goal is really to not only have them learn from us as instructors, but also their peers that are attending the intensive with them. People have been those that have been in the industry for a long time have a lot of valuable lessons learned and things they can share where others can glean from that as well, especially if we have newer ones attending that might just be getting started in the hospice industry. So they can be a very valuable resource.
Well, this sounds great. And I think it sounds like a do not miss for our hospice provider listeners out there. Well, Keri, thanks again so much for spending time with me to talk about this important topic today.
Thanks for having me, Jennifer. It was a pleasure.
And thank you to all of you out there for taking a few minutes out of your day to listen to our podcast. From me and the entire CHAP staff, keep your quality needle surging forward, stay safe and well, and thanks for all you do.